Good afternoon, everybody. I'd like to welcome to the stage Dr. Sarah Bowen.
Thank you. Hi, it's wonderful to see you all here. Am I good? Yeah? Okay. So a colleague, I believe, was going to come talk about me a little bit. I think we had a mix-up here, so I'll talk about myself briefly before I go into this. Just to give you a little context of where I'm coming from, I've been involved with Mind and Life now for, I don't know, 7 or 10 years or so. So it's such a pleasure to be here. It's, as you all know, a very special gathering of people and a kind of dialogue that I don't see anywhere else. I am a clinical psychologist. I am currently at Pacific University in Portland, Oregon, and I've been working throughout my grad school career and over the last however many years since then on improving treatments for addictions. I work primarily with substance use. I'm interested, however, in just the whole process underlying addiction of any sort, addictive behaviors. And working to try and understand the mechanisms underlying addiction so that we can have treatments that really target those mechanisms accurately and precisely. So before I started graduate school, I was finishing up undergrad and I needed 1 credit. So I took some course where you entered data, and I ended up in a lab with a radical behaviorist, Dr. Bob Kohlenberg at the University of Washington, and became really interested in what it was I was coding and listening to. And had a wonderful grad student there who kind of took me under his wing and started sneaking me into the seminars, the grad seminars, and like handing me the articles and giving me Skinner books, and just became really impressed with the systematic way of understanding behavior and the potential for behavior change, that behavior does actually follow some rules. Then I went to grad school shortly after that and began to study addictions. And in my first year of grad school, also began to study and become very involved in meditation and started going on retreats and getting fairly serious about practice. So I had all of these 3 things kind of bouncing around my head, ways of understanding the world, the behaviorist viewpoint, then this mindfulness and meditation that I was beginning to learn about, looking at cycles of addiction, and really trying to understand those deeply and reconcile them. So I've been thinking about this for probably 15 years now, which either means it's very interesting or I'm very slow. We'll find out. But that's basically what I want to talk about today, is how can behaviorism, which oftentimes we think of as very, rats and levers and lights and pellets and such, mechanistic stimulus response, and mindfulness practice, which often we associate with much more contemplative, internal kind of observation, how are these actually overlapping? And how can, maybe more importantly, how can each help us understand the other? So how can the principles of behaviorism and learning theory help us understand perhaps some of the processes that are happening internally when we practice, and vice versa? How can mindfulness practice extend behaviorism to not just external behaviors and factors, but also internal processes? So hopefully this will be of some interest to others as well. And a fun intellectual exercise, but ultimately what I would like is to better understand these systems and apply them to addictive behaviors and improve our treatment for addictive behaviors. So just to remind us all, myself included, why we do this kind of work. As you all are very well aware, I'm sure, addiction is very, very difficult behavior to deal with. People try so hard to change, and they oftentimes almost always relapse at some point. So I show this slide a lot. This is from 45 years ago now, but if you look here, these are survival curves. So this is basically showing people fresh out of treatment for heroin, smoking, alcohol, different studies. 2 weeks out of treatment, they're doing okay, and then within 3 months, half of them have already relapsed. 45 years ago, this is what it looked like. So then you look at, 35 years later, whatever it is, and you see, wow, this is a study of alcohol post-treatment, similar relapse rates. And then you look at 2012, and you look at 2005, or 2, 12, 10, 14, you get the idea here that while there's wonderful work happening in this field and very brilliant minds working on this, relapse is still so prominent and prevalent that we need to continue to expand our thinking and our approaches. So I'm going to give a brief review of basic Psych 101 behaviorism. For many of us, it's been many years since we took that class, so I'll make this brief and bring it back around, I promise. But a little bit about behaviorism. Skinner, radical behaviorism, believed that behavior can actually be systematically understood, systematically changed, once we understand what creates it and reinforces it. Therefore, it's observable and measurable. This is external behavior. So the radical behaviorists certainly acknowledge that things happen inside that are unobservable, but what we're focused on and what we're measuring is the externals, both the things causing the behavior and then the output. So Skinner said the external environment is what shapes our behavior. And therefore, that we can apply controls to our behavior, we can change and shape our behavior by changing the environment around us so that we can live better with each other and with ourselves. So he wrote this really interesting book called Walden 2. I believe it's his only work of fiction. And it basically described a utopic society in which all the external factors were controlled in such a way that everyone's behavior was shaped. So everyone behaved perfectly, was happy, got along well. So the basic principles that that's based on is that our behavior is a product of learning. And we learn in two basic ways. Classical conditioning, which is basically learning by association. I'll give you some examples in a minute. And operant conditioning, which is learning through the consequences of a behavior that we emit. And both of the behaviors that can be shaped through these conditionings can also be extinguished through this. And again, we'll look at some examples in a moment. So classical conditioning, learning by association. I'm sure this will look very familiar to many of you. Yes? Okay. So a dog hears a bell ring, doesn't care, so what? It's a bell. Then that is paired with food, bell, food. But initially, the dog naturally drools to the food, right? And then if we repeat this pairing, bell plus food, bell plus food, bell plus food, pretty soon, this stimulus, previously neutral, didn't elicit anything from the dog, now makes the dog drool, this conditioned response, okay? So you see learning by association. Now, if we want the dog to stop drooling at the sound of the bell, we basically reverse this, where you ring a bell and there's no longer the food. So the dog's still drooling because this association is still there, still happening, still happening, still happening. Eventually, though, the dog learns, oh, there's no food coming, and stops drooling, okay? Make sense? Right. So operant conditioning is the other kind of learning through consequences. So we'll use an animal model again here because it's a very straightforward way of looking at these behaviors. So this is based on the principle of reinforcement. So responses from the environment that increase somebody's behavior are reinforcing. That's basically the definition. There are two kinds. There's positive reinforcement, and that is where you get something after emitting a behavior that increases the likelihood of that behavior continuing. So it's something appetitive, it's something you want, it's something pleasant. So you tell your dog to sit, you give the dog a bone, pretty soon the dog's gonna sit for you because it knows it's gonna get this treat. Negative reinforcement, this is the question everyone gets wrong on the Psych 101 test, right? It's not punishment, it's another kind of reinforcement that increases behavior by taking something aversive away. So let's say a dog has one of those cones on after injuring itself, and comes and looks at you with big puppy eyes and cries a little bit, and you give in and you take the cone off. Well, now this puppy has learned, okay, I know exactly what to do to have this aversive thing removed, and now I'm comfortable again, right? And as with the classical conditioning, both of these behaviors that have been shaped now can also be overwritten or relearned by no longer offering the biscuit. Pretty soon, if there's nothing offered to the dog for sitting, it may not sit so readily for you. Or similarly, if you don't remove the cone, the dog may learn, okay, that doesn't work anymore. Okay, is that all coming back? Okay, so animal models, but these, we study these because they're of tremendous value in treatment settings with people. So some examples where behavioral principles are applied directly and incredibly effective are in the exposure response prevention therapies. You see this primarily with fear, anxiety-based disorders. So what these are doing is oftentimes those associations that we were trying to form in the animals are actually harmful associations. So let's say this person, for whatever reason, is afraid of spiders, like deathly afraid of spiders. Pictures of spiders, the word spider, everything, very afraid, and it's kind of getting in the way of this person's life. They won't go camping, they won't go outside, whatever it might be. So in this case, the association is actually something that is not useful. So what's tricky is every time the person runs away from the spider, that behavior is reinforced by negative reinforcement, right? I get away from the spider, I feel better, so I'm going to keep repeating that behavior because it's negatively reinforced. And so these behaviors continue to escape. Yeah. So in exposure response prevention therapies, it's an intentional exposure to this feared object or situation. So I'm going to stay here, I'm going to look at the spider, or even a picture of a spider, and over time, that kind of reactivity, once I realize I'm actually safe, will start to diminish. That's the classical conditioning, right? That association is now loosening up a bit. And the response prevention piece, bringing in the operant conditioning, is that by preventing the escape, there's no longer the negative reinforcement. It's all making sense? Okay. Now notice again, as we talked about with Skinner, these are external behaviors. We have a spider, an external trigger, and then we have this observable external behavior of running away or escaping. So what I'm interested in looking at here is, can we apply these same principles that are quite reliable to internal behaviors? Do we really have to go around trying to rearrange our entire world and all the conditions of the world to be happy? Which, you know, we know from this week, many of us, you can do your part and it doesn't always work out the way you want. So is there another way to apply these same principles and have results if we don't have control over our external world? So I'm interested in just this exploration of, can we alter our internal environment the same way we alter the external environment? And can we apply these same kinds of exposure response prevention strategies to shape our internal experiences? And thus, the same extinction processes happen, but it's internally. So I'll give you some examples to make this a little clearer. Yes, and how. So as I mentioned, I work primarily in addiction. So we're going to look at this kind of the way behaviorally that this addiction plays out. But I think it's also applicable to pretty much any behavior that's not in our best interest or that's driven by kind of a pull or a push of conditioning. So looking at addiction, let's say that it starts by going to a party. There's a queue. There's a lot of queues for drinking. Go to a party, engage in this behavior, have a drink. And this happens repeated numbers of times. So already here, what's happening is we have conditioning, possibly classical conditioning, where I now associate going to a party with drinking, okay? And then I also feel good. I have a drink, I dance a little better, I talk to people a little more freely, I'm having a good time, it's pleasant. So we also have operant conditioning here, where that drinking behavior is now reinforced. So we have kind of a double whammy here of conditioning that's sort of a perfect setup for continuing this behavior. And of course here, positively reinforcing drinking. However, what often happens over time with people for whom this becomes problematic is they don't need the external cue anymore. It's not about going to the party. It's oftentimes shifts to internal cues. So this is, I think, a beautiful example from a participant in a research study we're working on down in the South, who explained it this way: I am a trigger for me. The constant chaos of my brain is my trigger. I want to be able to chill, but the second you're not chill, you're back to chasing. You're back to trying to use and make yourself feel better. So here for her, it's not about external at all, it's internal. And as we know from many literatures, this is the primary relapse trigger. When people are asked in studies, what is it? You were doing great and then suddenly you relapsed, what was it? The number one answer people give is, I was feeling something I didn't want to feel. I was uncomfortable. I couldn't take it. Then what also happens here that makes it increasingly difficult is over time, that initial behavior of drinking isn't enough anymore. Like the sensitivity to those, both physiologically and also psychologically, it's just, it doesn't hit as hard. I need more now to feel what I used to feel with it. So now my use is also increasing. And here, of course, we have negative reinforcement because I'm uncomfortable. There was this internal cue. I drank. I feel some relief now. It's not even pleasant anymore. Now it's just, I just want to feel okay again because I'm so uncomfortable. So I drink. I feel better. Negative reinforcement. So it's a perfect storm here. And that's not all, because then what often happens for people who are trying to control their behavior and they act in a way they didn't want to is they feel horrible about it. So there's this shame, thoughts, I knew I couldn't do this, I failed, I disappointed my family. Also sometimes some physical withdrawal or discomfort. So that adds to that internal discomfort and the whole cycle perpetuates. So you can see perhaps why this is, addiction is referred to as a chronically relapsing condition. So psychologists, of course, know this, and there's a number of behavioral approaches to addiction, and I'll show you just briefly what those are, and then I want to talk about how the work that we're doing here and the more internal work, the contemplative work, the mindfulness training, might be able to come in and fuse this model and make it a little more three-dimensional and effective. So currently, some of the behavioral models are taking advantage of this idea of exposure and extinction, right? So, okay, if I have someone who has an issue with drug abuse, I bring them into the lab, I show them cues, pictures of cocaine, whatever their drug is, over and over again, and they don't get to use the drug, eventually that will extinguish, right? According to classical conditioning principles. So, this works brilliantly in rats. You can give them, show them the light, they press a lever, they get the cocaine, and once you stop giving them the cocaine, they stop associating the light with the cocaine, they won't do the behavior anymore, we're okay, they don't have that drug seeking. However, when we look at people, we do indeed see this, both physiologically and also their own subjective experience, a diminishing of reaction to the conditioned cues. So now the person sees the pictures of cocaine, their heart rate isn't going up as much, and they're saying, yeah, I don't crave it as much, it's getting less, it's getting a little bit better. So they have this decreased reactivity overall. However, the problem is that these effects don't tend to generalize outside that context. They're very context specific, so you have to do it in every context that this person might use, which isn't very reasonable. And also there's this thing called spontaneous recovery, where after a period of time, sometimes it just reemerges. Even if it's in the same context, it's just, for whatever reason, that initial reaction is back. Now, one more way that behaviorists have brought these practices into addiction is taking advantage of the operant conditioning processes, where there's a kind of treatment venue where people are given rewards for maintaining their goals. So typically it's abstinence. So you're in treatment for, let's say, cocaine use, and you get your urine tested every so often, and when it's clean, you get some kind of reward, so like a voucher sometimes, or points that add up to something that you can go use. So initially, again, it's often effective. There are studies that show that people who are in this treatment, who are getting these vouchers versus aren't, they are doing better. They're abstaining longer, or abstaining at higher rates. However, as you might guess, once you take those vouchers away, now I'm out in the world again, nobody's giving me vouchers, those benefits tend to decrease, right? So here's where I just want to think about how can we expand this thinking? It's obviously there's some very reliable rules of behavior in here, but I think maybe it's limited, and that's why we're not seeing these effects with addiction. So can we expand our understanding of environment to also include the internal environment, not just what's happening externally? And do these same conditioning patterns apply? So let's look at these same principles, but now our environment is this. It's the body, it's the mind. That's now how we're going to think about environment. So there's this idea of interoceptive conditioning. So this process that tends to happen, same as it does with the bell and the food and the drooling dog, but now it's with processes that might be internal. So thought, emotion, sensation, something that occurs paired with another event may take on those same properties. So for example, if I have had a panic attack, even maybe just once or twice, and then suddenly one day I feel my breathing start to get a little bit rapid and constricted, and I've associated that with panic. So I start having these thoughts about panic, and it sort of cycles into panic. Here we've got condition. We've got those classically conditioned there together. So how about this idea of applying these exposure processes to that internal process? So there are therapies that indeed do this, where you can have someone have that internal now experience of difficulty breathing, maybe have them breathe through a straw so they can't quite get enough breath in, and allow them experientially to learn that that doesn't lead to a panic attack after all. So now we're not dealing with externals. The external can be anything. What we've dealt with now is, okay, internally, I have some discomfort that's been associated with panic, and now I am extinguishing that. So I can take that with me anywhere, to any context. This sense of interoceptive extinction. This has been referred to, I think, a lot of different ways. I think in a lot of ways it's similar to the kind of decentering that Zinda was talking about, and Liz also. It's more recently been referred to as decoupling, which I really like. So these associated things that are coupled together are now, that association is being overwritten between either an external experience and another, or internal rather, and another internal experience, like with a panic attack, or between an internal experience, like a craving or a feeling of celebrating, which I associate with drinking. Decoupling those as well. So here we have the typical stimulus response behavioral model. Here it is. And now we're just saying, okay, this may be internal. It may be cognitive patterns, mood, emotion, urges, thoughts, whatever, and this other internal or external reaction. And can we, through training, through an awareness of this process, and then some training, some internal kind of exposure, break this link? So I want to look at some of the ways that this has been applied. A recent meta-analysis by Levin and colleagues showed this, a number of studies that have evidence of this decoupling. This was with the acceptance-based literature and also the mindfulness-based literature. So in a number of different domains, some more mood-based, others very addictive behavior-based, there was evidence of this happening. After a treatment period, people were no longer having this association between these things. And I want to point out, too, that 11 of those were in substance use, which is really interesting. I think it lends itself very well to this because the processes are just so clear and so harmful. So I want to sort of give a hypothesized model here of how this works. So we're shaping our internal reactions by changing the reinforcers that are internal. I'll show you an example in a moment. So first of all, we need to be aware of this process, right? Otherwise, it's automatic, it's conditioned. We have no awareness, we really have no agency, it just happens. Once we're aware of this, okay, maybe we can make some different choices internally of how we're relating to things. And also increasing contact with other reinforcers. So maybe if I'm feeling anxious and I need that negative reinforcement of drinking, maybe this time I'm feeling anxious and I can contact some other internal resource that might provide some of that same reinforcement, something that might help me be with this a little bit easier so I don't have to escape. And also, I'm wondering if just the mere, and Liz Romer talked about this, I think, beautifully this morning, can the quality of awareness and exploration actually become positively reinforcing? So in other words, let's say I have that same anxiety reaction, and rather than having to get away from it somehow, that's my negative reinforcement, it's under aversive control, can I actually approach it and be curious about it? It's not comfortable necessarily, but is there something in that that actually aligns with something that matters to me that is going to then be positively reinforcing? Does that make sense? So rather than it being about the actual thing, the spider or the fear or the anxiety or whatever it is, doesn't even matter anymore. It's my attention to it. It's how I am with it. Can that become the reinforcer rather than depending on the object, which we often don't have any control over? So, for example, maybe I feel afraid or anxious, so I decide to escape up into my head and plan a lot, so I don't really have to be with that fearful feeling. It's very uncomfortable. And again, that's reinforced, right? Because I feel some relief. But if that same fear comes and I can turn towards it with some curiosity, might that then reinforce the behavior of approaching with curiosity? Okay. So I want to talk about some of the ways I've been working for quite a while with mindfulness-based interventions, specifically some with MBCT and then far more in depth with MBRP, mindfulness-based relapse prevention for addictions. So I want to talk about some of the ways that we've been approaching this with clients and what that looks like. So obviously, again, internal aversive experiences, what do? We run away, don't want to be with it. So when we learn to sit with this, okay, now we're going to ask you to sit with whatever comes up. Eventually, probably something uncomfortable or slightly aversive is going to come up. And there are many things we just do internally sitting there on the cushion, right, to get away from that. I'll start thinking about lunch, or I'll just sort of get tired and blank out, or whatever it might be, to get away from this really intense experience that I would rather not be with. So first, we need to learn to recognize, again, these conditioned reactions, right? Like, oh, wow, okay, I just went into that whole fantasy and planning because I don't want to be with what I'm feeling right now. And I recognize why that's happening. I feel that pull, like I really want to think about something else because that's much better than sitting with this. So I'm seeing what's happening now. And also, again, maybe increasing the sensitivity to other things that might be reinforcing. So as Liz Romer talked about this morning, maybe there's a way that being with something that's really uncomfortable is still really uncomfortable, but there's an honesty about it. There's a, I almost want to say sweetness about it, of just like, okay, yeah, this is here, and I can be with this, and I understand it's uncomfortable. And there's something about that that's it feels very wholesome, or can, potentially. So then over time, we have this repeated, prolonged contact. Now it's our attention. We're not touching spiders, right? Our attention is touching our internal experience. It's that same level of contact repeatedly over time, which is what it takes oftentimes with these exposure processes. So we're staying rather than escaping. And this, there's interesting discussion in the literature, like, is there such thing as unlearning, or is it really new learning that kind of overrides old learning, right? So whichever it is, there's something here that's changing that association and reshaping some of our behaviors. So I want to talk a little bit more about that kind of the way that I've been thinking about the subtleties of this process, or kind of exploring this. So if we imagine this blue orb as internal experience, okay? And the middle part is the direct contact with whatever's happening. So whether it's like physical, feeling your body, what's happening, whether it's like awareness of thoughts arising and passing, whether it's emotion, it's when you've brought your attention back to, okay, this is what's actually happening. And then this outer circle, let's say, is when we kind of go off into whatever your thing is, your to-do list, or judging yourself, or your ideas about what's happening, or whatever it might be. So we kind of have this more direct experience, and then kind of the virtual reality that our minds go off into. So oftentimes, when we're sitting, I'm sure you can all relate, it's really uncomfortable to be with that direct experience. You know, it's physically, it can be uncomfortable, emotionally, maybe there's thoughts that you just would really rather not be with. So we pop out, like automatically, right? It's conditioned. We know that if I just go over here and start thinking about something else, I'm going to feel some relief, I'm going to feel better. So that is conditioned behavior. It's not our fault. This is how it works. So this, I feel a little better. Maybe not happy, but a little bit better. So here we have this avoidance escape learning, which is negative reinforcement, right? It's just happening internally. So over time, however, what I'm curious about is, now that I know this, I know what my mind is up to, I'm sitting and I notice that I'm off and I'm engaging this, and it actually doesn't feel very good. It's not where I want to be. It's not what I want to be doing. So now that's kind of aversive to me. And I want to come back to what's really happening. I want to return to, okay, this is why I'm here, find the breath or whatever it is. I want to be present again. So now, okay, maybe the negative reinforcement is reversed. Does that make sense? So that kind of default virtual reality world is now aversive. And so I'm moving back into something that's now become maybe even appetitive, or at least removed me from aversion. So we have the negative reinforcement there, and then maybe positive reinforcement sometimes. You know, maybe sometimes it feels good. Maybe not feels good, but it's valued. It's what I want. I'm back home. I'm back with what I want to be. So maybe over time, through this kind of practice, we're reconditioning the behavior of our mind in this way, using these same Skinnerian principles. So in terms of substance use, again, I want to kind of now bring this over to look at some of the ways that we work with this in the Mindfulness-Based Relapse Prevention program. So oftentimes craving feels like this. You know, I don't want to do a behavior, I don't want to do it, so I just got to do this. So of course, once I use, I'm relieved, right? Because I don't have to do this anymore. It's negative reinforcement. I feel better. That's avoidance, right? Instead, what if, okay, a craving comes, and what if I can turn towards it and be curious about it? What if I bring my attention and my interest to it? So how do we do that? So this is actually what we train folks in our groups to do, is when craving arises, it may be craving for a substance, it may be any kind of reactivity, it doesn't really matter, it all functions the same, is when that craving arises, instead of trying to get through it or instead of trying to escape it, can we actually recognize it and turn our attention towards it and maybe bring some curiosity and interest in a way that may be reinforcing. So what is craving? Really, what is it? Sometimes it's physiological, sometimes there's thoughts, there's this kind of discomfort or sense of urgency, there's sort of a valence to it, certainly, so maybe some emotion there. And also, this, you know, what is that urge? It's so interesting. What is that? Is that physical? Is that cognitive? And also what we started working with, too, is looking at what is really the function of this. So the craving, I'm reaching for something, that's not really what I want. I want to feel a certain way. That's what I want. So beginning to look at the underlying needs, or what's really happening. What am I really reaching for here? So again, we're engaging some curiosity here rather than having it be aversive. It's maybe now a little bit appetitive. I want to know what's going on here. I can move towards this. And so we have this sort of approach-based coping, or positively reinforcing curiosity. So another way that we explore this is a practice that we have begun to call it false refuge. So understanding, again, what it is we're really wanting and what it is we reach for. Often two different things. So when I reach for this, what do I really want? So here there comes in the expectancies. I'm wanting either relief, negative reinforcement, or to feel good, positive reinforcement. So that conditioning is pretty strong. And so I either want to run away or I want to feel really peaceful. I want relief or I want a feeling of peace, perhaps, for example. So by recognizing this, we've seen what's really going on here. And then we just ask people to think about what do you actually end up with? If this worked, great. You wouldn't be here, you know? If this were actually an effective way of getting away from something you don't want or getting something you want, it would be wonderful. It wouldn't be a problem. We wouldn't have addiction in this way. So how does it end up actually playing out? And what people often say, it's so interesting, almost to a T, you know, you put this in two columns. What do you want? What are you expecting? Like freedom, relief, escape, joy, peace. The other column, what are you actually getting? They're almost always exact opposites. It's wild. I wanted a sense of peace. What I got is, I feel horrible. My mind won't shut up. This is not peaceful at all. Or I wanted to feel a sense of belonging. I feel really lonely. Then I drank, and then the next day I just felt horrible. I excluded myself. I feel really isolated. I feel really alone. So it's a cruel trick how that works. And here, too, what we're trying to do is, rather than propose that this is the way that it is actually have people explore this and see, how is it for them? It may or may not be true for people. But take a look and just explore what's going on in your own mind and body, so you can become an expert on yourself, so you can see these processes, and then do as you will. But at least you know how it's working for you. So another way that we work with this idea of exposure, interoceptive exposure, coming in contact with things that are really difficult, is a practice called urge surfing. This comes from the original relapse prevention, which was very cognitive behavioral, and this was sort of a metaphor that Marlatt and Gordon in the 80s used. It wasn't so much an experiential practice, but it was a useful metaphor of, like, imagine you're craving like a wave, and it'll go away eventually. So we've kind of taken this and tried to really sink down into it experientially. So if we look at this, of course, behaviorally, what we see is this experience of intensity, whatever it might be, over time, feels like it's going to go up and up and up until we make it stop, oftentimes, right? Like, I can't stand this, and you do something, and it goes away. So brilliant, goes away, and that's negative reinforcement, so that's reinforcing that behavior. It's just strengthening it. It's making that urge and that intensity even stronger, and that probability that you're going to avoid even stronger, right? However, instead, it looks much more like this in reality, but we need to learn this experientially. We know this. We know it's not going to go up, and I'm going to crave until my body blows up. We know that's not going to happen, but we don't feel that way in the moment, whatever it is, whether it's anger, anxiety, sadness, whatever it is. So we use this metaphor of a wave, of, okay, imagine that this is much more like a wave. Waves change over time, they come and go, they ebb and flow. And what if you could surf it? So you don't have to fight it, you don't have to try and make it go away, you don't have to give into it, but maybe you can just ride it and know that it's eventually going to go down. But this takes skill, as does surfing. So the idea is, can we stay with discomfort as it rises and becomes more intense? This contact here with our attention, again, is that exposure, right? We have to train to do this, How do you do that? How do you stay without just doing this? How can you relax into this and stay steady? And then learn. We say trust that this happens, but what is trust? It's learning. So yeah, I did this, and actually, it did go down. Right, I might try that again. That was interesting. So naturally, this is going to subside. This is a process that behaviorists call habituation, where that intensity, again, is going to go down over time, right? It's not going to be that intense. If we can stay in contact with it, the reactivity will lessen, and then the behavior can extinguish. And over time, it gets easier. So another practice we use in the same kind of vein, but really trying to bring all this together, is a practice that we really borrowed from MBCT, from Zindel Siegel's work, the 3-minute breathing space. In the relapse prevention groups, we find that acronyms are very helpful. I think largely coming out of the kind of 12-step program, where oftentimes there are just things like, if you can remember those in the moment, the bumper sticker kind of sayings, like, remember those in the moment, it can be really helpful to, oh, right. So we use this acronym SOBER for people it's helpful for. And the first thing is to stop. So here, let's say there's some reactivity coming up. I'm about to do something I recognize as reactive. I've learned to feel these triggers. I know what they're like in my experience, and it's happening. My heart's going, my mind's going. I have this urgency. So first, okay, I recognize this, right? Okay, stop. And then recognizing the conditioning. Now I know what's happening. I know that, yeah, if I do that, I'll feel better temporarily, and then something else will happen. But now I know this is conditioning. It's not my fault. It's conditioning. It's how we're wired. But I can pause here and take that attention that's so fixated on whatever's happening and turn it inwards. Say, okay, what's actually happening here? So 2 things going on here. Obviously, we have the exposure again. So now, instead of being out here and being reactive, I'm in touch with what's happening internally. So there's that exposure. And also, maybe there's that switch from being under aversive control to actually approach-based curiosity, positive reinforcement. And then also this sense of, okay, I can choose where I put my attention at this point. And I'm going to bring it even further and get a little more subtle and just attend to the breath as a way to get back to what's actually happening here. My mind is doing this stuff. My body's doing this stuff. These urges are happening. How can I just get in touch with, very simply, what's going on right now? Okay, sensations of the breath, okay. And also this beginning to really sensitize, so it's not just the loud emotions or thoughts or feelings or input from the drugs that I feel. Now I can feel like I can get more sensitized and be in touch with these other factors that may be helpful or reinforcing. And then expanding back out. Okay, now I want to get in touch again with my experience with this more kind of steady attention versus being reactive and feeling like I'm going to just behave based on conditioning. I've steadied my attention a bit, and now I have this ability to respond. So what is it I really need? Okay, I really need to just to step away and feel some safety. Okay, what can I do? That's probably the practice that I think is really at the center, the urge surfing in the sober space of the program. And it's the one that when we followed people up, even for a year afterwards, we ask, what are you practicing? Are you still practicing? I see people nodding who've done this before, who are therapists in MBRP. It's the sober space people seem to really use in their day-to-day life in all kinds of situations. So we did a trial that we published a couple years ago now. I'm not going to talk too much about the data. It's available, so I'm happy to share that with you or point you to it. But I just want to see how this kind of theory or way of seeing this process matches up or doesn't with our data. So this is a study that we did in a treatment agency that really served folks who didn't have a lot of other choice. A lot of folks are court mandated there. A lot of folks can't afford other kinds of treatments. This is where they go. It's a wonderful facility. And we went in and did a trial. We've done a couple trials there. This one, we randomized people after they had gone through some kind of treatment. So they were stabilized somewhat. They were through detox, maybe been through a month or so of intensive outpatient or inpatient treatment. So they're kind of ready to, okay, now how do I live my life? How do I do this? That's where we want to come in. And we randomize people either to the mindfulness-based relapse prevention, where we're using some of these practices, to a standard relapse prevention, which is cognitive behavioral therapy, a lot of good data. It's effective, it's helpful. And then treatment as usual, which was primarily 12-step based, but really sort of a mix of, depending on what the counselor's orientation was. This sort of treatment as usual in the community. A little bit about our sample, about middle-aged, primarily male, high rate of unemployment and public assistance, also quite a bit of homelessness. And here's we had some nice ethnic diversity. This is reflective of the area of the city in which we did the study. And here you can see also the breakdown. So we had a lot of different kinds of substance use. It's probably quite small, but alcohol was the primary. Many other substances, however, the majority, 80-some%, were polysubstance users. But when asked you, like, what's your primary, drug of choice, alcohol was the most common. And what we found, we followed them up for a year after they finished the course. And what we found is that initially, here you can see that the mindfulness-based group and the RP group, so this is post-treatment, everyone's not statistically different there coming out of post-treatment. Then at 6 months, treatment as usual folks are starting to drink a bit more. You can see on that axis, that's number of days of drinking. But the MBRP and RP are still doing pretty well. But then what was so interesting to us is what happens here. Now the RP folks are already starting to use again. There's something where these treatment effects are wearing off for some reason. But the MBRP folks here, there's something that's helping them sustain and maintain these behaviors. So we've been kind of trying to make sense of these data for a while, and I can't point to anything that we measured. So this is a hypothesis. I don't know if this is true. But my thinking is perhaps one thing is this: the treatment as usual condition was very much about hold on, hold on, hold on. You got to like do this, and then at some point I can't stand it anymore, and I relapse. And there was a lot of education, which I think is very helpful, and a lot of content processing. A lot of like, tell me your story, how was the week, how did you get here, that kind of thing. So very content-oriented, where my addiction is tied to my content of my life, my story. In the relapse prevention, a lot of skills that are very helpful, they're also very specific to the situation. So in other words, like for example, one exercise is drug refusal. So okay, I know if I walk down that street and I see that guy who I used to buy from, he's going to offer me this for half price, and I'm, okay, let's play that out. So very useful to expand the repertoire of behaviors there. One concern I have about that is oftentimes those situations, two things. One, it's a low base rate. That may happen to me once every 2 months, so I don't really get to practice very much, right? If I were practicing drug refusal every day, I might get better at it, but if I practice it once and then not again for 2 months, does that learning stay? And another thing is maybe the situation changes. Maybe I move. Maybe now I'm in a relationship and that's too much for me, and now my triggers are related to that. So it's very much on the external content here. And also, there's a kind of an avoidance-based, I think in a skillful way, again, I'm all about this program, I think that's tremendously useful. But there's a lot of kind of identifying and avoiding things that are going to put you at risk. That makes sense. But again, if we keep avoiding, we don't get to be in contact and have that kind of extinction processes happen, possibly. So when we look at MBRP, what we're really working on training is, again, the awareness of these responses. So whatever context someone might be in, whatever situation someone might be in, maybe they can recognize what's happening here. Staying with discomfort, whatever it is. So any situation that brings me any kind of discomfort, maybe now I have that skill to kind of decouple that discomfort with the thoughts or the behaviors. And also this idea of identifying, learning more about myself. What is it I really need? This isn't it. What is it? Being able to ask that question. So this is another interesting thing I've been thinking about too. If we look here, basically what we see is the younger folks here, under 30, and then between 30 and 48, and then over 48. And you can see that first block there, the treatment as usual, the white, the gray, the relapse prevention, the black, the MBRP, that people are actually using more in the MBRP condition in that age group. So this is a moderator of our results here. But then you look at the middle group and the older group, and they're using much less. They're doing much better. So what's that about? I don't know. Again, one idea, one hypothesis is it reminds me a bit of the MBCT data where people who had more of a sort of severe history, number of relapse episodes, do better in MBCT than those who had fewer than 3. And here, I think that correlates highly with age. The younger folks who come in, oftentimes first-time DUI, whatever it might be, they really are attributing it to external circumstances and not ready to maybe even look at the fact that that's not the case. And also, I think as we get older, these patterns become more conditioned. So that coupling becomes even stronger. Yes, when I feel this way, I drink. I've been doing that for 40 years. That's going to be much stronger. And so maybe this kind of intervention has just more potential for that. Again, hypothesis, I don't know. With these data, there's no way we can really know that. Just thought that was interesting. So I also want to mention, because I just talked about that trial, because it's what I know, but there's such great work going on here with college students in women offenders. Garland's work, who I see back here, is wonderful, working with opiate addiction. Sam Himmelstein's work, working with youth, incarcerated or adjudicated youth. And Peggy Lee Wupperman, working with more aggressive behaviors in women with substance abuse. and then wonderful kind of overall reviews and meta-analyses. I just mentioned these because I think a lot of this work touches on these same processes. These are all mindfulness acceptance-based approaches that I think are looking very, in a much more fine-tuned way at what's happening here. So I wanted to take the last few minutes to tell you about some of the studies that we're doing currently. I've got almost all the labbies right here in the front row, so this is really their work. So one thing we've been working on is applying this to smoking cessation. So this is primarily the work of Taylor Proper and Aaron Bergman, who have been kind of designing the study and going through the initial stages here of building this up. This will be Taylor's thesis. And the idea here is, again, remaining in contact with internal discomfort that happens when someone wants to smoke. There's traditional cue exposure therapy, which looks like the earlier example, where you'd sit in a room with a bag of cigarettes, touch them, put it in your mouth, hold the lighter this far away, smell the smoke, and supposedly then habituate, and you wouldn't react as much. However, as we looked at before, that doesn't always work once you're in a different context or after a period of time. So here the question is, what if that exposure is, again, internal? So this is based on some previous evidence that suggests this might be the case, a study we did a while ago, where it's just a lab-based brief kind of analog study where we did see, in fact, after about 10, 12 minutes of sit with the external cue, look at the cigarettes, focus on the cigarettes, versus here's the cigarettes, notice internally what's happening. We saw differences between these groups. Specifically, we saw that the negative affect that was coming up was not as related with the urge in the folks who had done this kind of interoceptive exploration. And also the urges to smoke were not as related to the actual smoking itself, so that decoupling again. Similar results in another study where there's this decoupling between the craving and the smoking behavior. This was based on a similar protocol, but actually an 8-week treatment. So again, we have this stimulus response. Can we get in there and somehow change that relationship? So this would be a brief nicotine replacement therapy adjunct. So people who are coming in for nicotine replacement therapy, they get the patch. Basically, their overall craving comes down, but oftentimes they're still in danger when they have these acute triggers. And so can this be a helpful addition to that? And also looking at how can these same processes be useful for people with comorbid substance use and trauma. This is work of Vanessa Somahana, will be your dissertation. And integrating MBRP primarily with more sort of gentle exposure-based treatment to trauma. So again, it's looking at this interoceptive exposure to very distressing internal experiences, and how can we help people learn to stay with that, and to understand that those reactions, that aversion, is just a reaction to what's happening in the body. It's not a reaction to an unsafe world. It's not a reaction to the trauma happening again. To recognize that and decouple those associations. And also, can we, again, help people understand the conditioning that's happening? That, yeah, substance use is just because I want to feel better. What I want is to feel better. And using that curiosity and kindness, again, to maybe turn towards the experience instead of pushing it away. So I just want to end with, I'm a big believer in data. I also think that some of these clients, the things that they have said, just really capture this far better than data or I could. So I want to share a couple of those with you. So awareness of conditioning. I feel like I've gotten a lot of acceptance and compassion towards myself. You can't change how you're feeling. I mean, there are things you can do better, but there's a lot of things you just can't change, and you're really programmed to do. Conditioning. And the mindfulness keeps you aware of the programming, of your own body program, you know? And I like that. And at the end there, that little turn of like, there's something cool about this. Even though I don't like what's happening and I can't control it, I like that I'm aware of it. Maybe there's a little bit of that positive reinforcing quality in there. An example of the interoceptive exposure response prevention. Before I'd react to emotions just because I had them, because I felt them, after we did urge surfing, stuff like that, I've noticed I can actually feel what I'm feeling, but not react to what's going on. So I can be with this and decouple it from that reaction. Another example of that, I paused and watched my breath. The urges and thoughts would keep poking their heads up, but they got quieter and weren't as big of a deal. Habituation, right? I sat until I didn't feel like I had to act on these anymore. Finally, I saw the situation clearly. I could make a different choice. So it's still happening, but the reaction is discoupled, and I see that I'm free. And then finally, this shifting again from the avoidance to maybe a turning towards experience as positive reinforcement. I always wanted to stop using drugs, but then the chaos keeps coming. The judgments keep coming. You're spinning again. Now I'm just like, I'm not taking this on, and that's just awesome. This is a freeing, freaking thing. I feel freed. So again, this incredible discomfort, I'm turning towards it, I'm free. I don't know what's more positively reinforcing than that. And then finally, can we resensitize ourselves to the quieter things that maybe will be nourishing, so we don't need to reach for things, the bigger hit. I feel I've become more focused in the moment. All my life, I'm just going automatic pilot. In this group, it helps me be focused more and pay attention to the little things, value the little stuff. So in closing, here's my final hypothesis. Curious about your thoughts. Behaviorism here. We have mindfulness practices, mindfulness-based interventions over here. And this huge parallel, these same processes we're talking about. Behaviorism sees the self as just a series of processes. There's no noun here. It's all verbs. It's all just things happening. And it's all shaped by contingencies. It's all conditioned. And similarly, we might see self in the mindfulness-based approaches as conditioned and just a series of processes. There's no self. There's no fault. This is just how things are conditioned and how they work. Behavior is under the control of positive or aversive reinforcement, appetitive or aversive control. And here, influences and consequences of craving and aversion as very strong driving forces and causes of suffering in our lives. So can we bring these together to help people, ourselves and people who we work with, understand and recognize these poles of conditioning, the awareness, train ourselves to override and overwrite that conditioned behavior, have that increased willingness to stay in contact with that experience as a way to be free from it. And also sensitize to these subtler reinforcing qualities that can be related to anything, doesn't matter what's going on externally. Can I bring curiosity, kindness to it? And ultimately practice a systematic, reliable way to relieve suffering that doesn't involve trying to rearrange the world around us. And I just want to give a thank you to funding sources, colleagues, my lab, partners, mentors, clients, participants. So we have 1 minute and 20 seconds for questions. We can also, if the room is available, I think it is, I'm happy to hang out for a little while and answer any questions that people have. Yeah? Can we get that one turned on? Is it working? There it is, yeah.
So I have a question about moving this into behavioral addictions.
Yeah.
I do work with, say, video game or internet addiction.
Great.
And certainly we see some of the same types of, I've got some data on cue reactivity towards video games. It looks like, may begin with some dysregulated coping. So many of the same types of things.
Sure.
But one of the other things we've noticed is this broader set of needs.
I'm sorry, broader set of?
Of needs.
Okay, yes.
So for example, if we think of self-determination theory, an ABC of human needs. The A is autonomy, we want to feel in control. The B is belonging, we want to feel connected to people. The C is competence, we want to feel good. And you can imagine how video games are really good at all three of those.
Yes.
That alone doesn't seem to be enough to move it into an addiction. But if kids are not getting their needs met in the real world on one of those levels, but do get them met, so it's that imbalance.
Yeah. Sure.
Then that seems to be a significant risk factor for addiction. So that's a broader need, I guess, and you put needs into your model. I guess I'm wondering, how would you see this relating to that kind of imbalance in need? Because that's not so much a cued thing. That's not so much,
Sure.
you know, that's a bigger issue.
Yeah, that's a great question. I don't know. I mean, I think that this model is really formed around people who have that really strong conditioning and reactivity. But what about those earlier stages where it's a little more subtle, but we're reaching for things that are fulfilling a need that's not getting met elsewhere? And also, if you're talking about youth, are they motivated to change that? I mean, most of our folks in treatment are pretty motivated to change it, but at that stage, there's something else going on there too. It's actually working for them, they think, right? It's actually, or we think, if we're grabbing for whatever, if it's not a problem yet, it's a little bit harder to. So I don't know. I think it's a great question. I think depending, of course, on the circumstance, how can we identify or help that person identify what those needs are that are getting met? Maybe they just want to zone out, whatever it is. First, I think that's a first step, is what's going on functionally. How is that functioning in this person's life? What's happening? Are they trying to isolate? Are they trying to numb out? Are they trying to get away? What is it? And looking at that, I think, first, and then seeing how that might be addressed. So in other words, I don't know that we can say all behaviors that have the same topography are functioning the same, right? So I think it depends. Thank you for the question. Yeah.
Hi, really enjoyed your talk. Thank you.
Yeah.
In the case of opioid addiction, it seems to me that there are tremendous advantages of MBRT over conventional treatment with drugs like buprenorphine and methadone, but that those two types of therapies may be incompatible. I'm wondering
can you say that last part again? I think
those, MBRT versus treatment with buprenorphine or methadone may be incompatible types of treatment. And I'm wondering if you agree, and if so, if you could, elaborate.
Why do you say they're incompatible? I'm curious.
Because if you're just kind of substituting one substance for another, then that may interfere with training and sitting with discomfort and
Sure.
Yeah.
I think this is a great question. It's something we've actually been working with in our lab. In our lab, we've been working with methadone maintenance folks in seeing if this kind of, if I'm understanding your question correctly, I had a little hard time hearing. How can this be applied to people who are on this case on methadone? And again, I hate to sound like a behaviorist, but well, I love to sound like a behaviorist, but it's I think it's, again, looking at the function. Like, if that's what it takes, that's what it takes, and I think that's wonderful. If that's going to save someone's life, great, let's do it. But let's not have that be the end, because oftentimes, when people are on these therapies, that's it. It's like, you're treated, here's your meds, go, next. And I think that's really unfortunate, and that is a really skillful beginning step for some people. It's harm reduction. It's better. What's happening now is better than it was. And now what? If you want to stay on this, how can we help you live your life more fully? Or if you want to go off this over time, how can we help you do that? Yeah. So with the study we've been doing, looking at some of the reasons that people are afraid to go off of it, and some of the ways it's a barrier in their lives, and how can these kinds of practices be helpful, and if so, how? But I think it's a great question that we also don't have a lot of answers to yet. But I think there's potential there, of course. There's potential there, too. I'm not sure that they are actually at odds. I would question that, yeah.
Thanks.
Thank you.
Remark on that you guys are mentioning a critical piece of that.
Please.
Specific is chronic pain. People are going to be living in chronic pain.
Yes.
Sometimes I don't think they're incompatible, by the way.
Yeah, thank you.
Thank you, huge fan. I feel like I'm meeting my favorite celebrity. So my question is about the larger scale, about the research community, as far as the compatibility of Buddhism as a large belief system and the scientific program, kind of like a research agenda on decades of scale. So if we were to summarize everything you've said and all the other psychotherapeutic, clinical psychology approach as the way out is in, kind of like, to kind of get out of this, you kind of have to go in to be kind of sustainable. Otherwise, it's just going to manifest as something else and come back. So the thing is, the Buddha kind of said, well, things are not going to end until nirvana is reached. And this is why this is my whole program. It's kind of like cognitive behavioral manual. So my question for you is, now the mindfulness literature is kind of like emerging and saying that we're kind of at this dilemma where mindfulness itself is not enough to address a lot of folks where you'll overlap. Those folks kind of on the shade of not taken care of. People with trauma, autism, developmental disability, just traumatic brain injury, where the way out is in, the in is too hot, right? So the trauma just gonna flare up all the way. So my question for you is like how, and then, as a maybe mindfulness-based researcher, I would reach into Buddhism and say, this case is not that mindfulness doesn't work, it just calls for something else. It calls for the right wisdom, right view, whatever, in the Noble Eight Path. That's not gonna work with the insurance company. They wanna see this manual works by itself. So if my ultimate, passion is like to validate something that can work, be validated, and reach like minorities, do you have any like long-term direction that you're thinking?
Oh, that's a great question.
Solve all the problems.
Yes. It depends. Yeah. I have several sort of responses. Obviously, I don't have answers. I think this is a wonderful discussion. It's actually, we're doing a panel right after this talking about this, is what is that intersection? What is that conversation? Is this skillful, or are we really missing the boat? Is it just this for this and then maybe more later? I don't know. What I do know is with the populations I've been working with, this is enough for now. I don't know that, at least maybe somebody else could bring more skillfully some other pieces in, but this to me seems already so huge, such a huge shift for people in viewing their own experience in their lives and the possibilities and their sense of agency. So that's sort of where we've rested for now, is how can we do that part better? And then, this is a tiny little pixel on a huge picture, I get that, which is why we need all of everyone to do this. It's a great question, and I genuinely look forward to your work and seeing how you kind of grapple with that and work with that. Thank you.
Hello. I'm wondering a couple things. One is you pull pretty comprehensively from behavioral theory to inform this model, and I'm wondering, given all of the different elements, the different reinforcement elements, the different extinction elements, combined with the elements of mindfulness, acceptance, and so on, I'm wondering which of those mediate the positive outcomes, and is it possible, with respect to the age difference moderation effect that you displayed, that some of those mechanisms may not operate for younger folks? And I'm wondering if you've tested any of that.
Say the last part, may not operate for what?
For the younger folks.
For the younger folks, yeah.
So I'm wondering if you've tested any of that.
That's a great
any
question.
Insight.
Like, might there be different mechanisms at play depending on the different age groups? And that's why we're seeing the outcomes or lack of outcomes. Yes. And the first question, in terms of mechanisms, the research is so gross and clunky compared to the actual nuances of experience. So what we've seen from our clunky measures in terms of mechanisms is we see evidence for, one thing that I think is most interesting and relevant that I didn't have time to show is there is evidence of that decoupling that we've seen in a couple studies now. So that people who are still after the group, control group, mindfulness group, they're still experiencing the negative affect at the same levels. But what's not happening is it's not coupled as tightly with the craving. So that's it's a moderated mediation. So it's mediating for the folks that didn't take the mindfulness course, negative affect craving use. And that relationship has been decoupled for the folks who did take the mindfulness course. That to me, like when I see those results, like, oh yeah, I trust that. Another interesting mechanism we saw is self-efficacy, which is usually touted as one of the main mechanisms in RP. standard relapse prevention, self-efficacy, this sense of if I'm in this situation, I can handle it. If I'm in this situation, I can handle it across all these different situations, and that's predictive of outcome. What we saw is that was actually a stronger mediator it was actually a significant mediator in the mindfulness group, not the relapse prevention group, which is not what we expected. We thought cognitive behavioral, self-efficacy, and what we saw was, no, it's actually happening strongly and more reliably in this other group. And that, again, makes sense to me because if I know I can be with discomfort, put me in any situation, and I more or less skillfully, I may make mistakes and flop all over and be uncomfortable, but the situation doesn't matter anymore as much. I've done this, I practice this, I know I can be with this, and that is actually predictive of outcomes. Does that answer your question?
Thank you very much.
Yeah, thanks.
Hi, as a young person, decoupling works great for addiction, so there you go. My question's about the cultural embeddedness of this mindful relapse prevention program. So 12 steps isn't going to go away. It's what works. I mean, it's what people feel works. It's what they've known to work. If you're from a not affluent, upper class and educated area, that's probably all you have in your area, a 12-step system. So do you have any thoughts on embedding this successful mindful program within the 12-step system?
Yeah. So another one of my grad students is working with that very model. I think what I've noticed about this that I really appreciate is these studies that we did were in the context of very 12-step based thinking and culture. And at first I didn't know, it was like, oh, I have to say why this is different. And I learned very quickly that that wasn't the case at all. It was actually for people who needed something different, it was something different. For people who really AA resonated with them and it's working for them, and this is a program that saved their lives in many cases, it was a support. That there's really this idea, we just keep coming back to the serenity prayer of, all right, first you need the serenity to see clearly. I missed that part for a long time, like, oh yeah, the serenity comes first, okay, in that prayer. And then what can you change? I can't change the whole world, I can't change that. What I can change is my relationship to it, and that does take courage. So I think in that sense, they're very beautifully integrated. I think on paper, you can make a really good argument for how they're theoretically opposed, but I find that in the room, that just isn't the experience of the clients. So,
Thank you.
yeah. Sure. Wonderful. Great, thank you. Thank you. Free books. Okay, 2 more, and then I'm going to need to move to the next. Yeah.
Yeah. Thanks so much for your talk. So just wanted to follow up on something you mentioned more broadly about the field, about how we've just got these clunky measures, and as someone who's new to the field, I'm finding we have clunky terms too, right? There's decentering, there's decoupling, mindfulness, reperceive. Like there's so many terms that seem to discuss largely the same thing. So I'm wondering how can we address that as a field? What can we do to clarify some of that stuff?
I think come to things like this and talk to each other.
Okay.
I don't know, really. I'm curious to see how it goes. If it becomes more divergent, like the DSM, it's like gets bigger and bigger and more terms for the same, like can we just look at the same process and call it the same thing?
Right.
Or if it's really going to get more refined, I don't know. How we can address it, I think, is, I know for me, it's listening to other people and not having to be attached to my own ideas and names for things and acronyms and whatever. Like actually listening, oh, we're talking about decoupling. I'm not going to call it my word anymore. So I think some willingness to do that, and then just to, keep these conversations going.
Thanks.
Maybe. I don't know. Yeah, one more.
I was curious about, you had mentioned about referencing Dr. Romer's talk earlier about just the idea of attending to your experience as being kind of reinforcing in some way or pleasant. And I was thinking about both in psychology and in clinical interventions, there's the kind of like the wise mind and the self-compassion, and then even in contemplative traditions like loving kindness and affectionate awareness for your experience.
Can you speak up a little
Oh,
bit?
yeah, absolutely.
Thanks. I got you so far, but it's a little hard.
I sound loud, but I'm not. And so I was thinking about, I wonder how if you've thought about how sort of attachment processes and self-compassion and just like self-kindness fit into that quality that you're talking about of just how it's nice to be with yourself even in a period.
Tell me that last part.
How it's nice to be with oneself even in a period of difficulty
Yeah.
in some way.
Yeah. Yeah, thank you for that question. And I think one thing that I am often guilty of is not making that more explicit. It feels to me that the approach is all about compassion and kindness. And that quality of being with your experience isn't this. It's like, oh my God, this is really hard. And I can stay with this, I can be with this. And I'm being encouraged by this group of people in the same process. And there's just a, like, of course, you know, sort of quality to it to me of, we're human. This is being human. It's hard to be human. And I do think, and there's, you know, some folks working with this and bringing in another person in our lab, actually, my students are wonderful, who's working on maybe bringing some of the more self-compassion, explicit self-compassion, targeted self-compassion practices into this, you know, for this population. Yeah. So thank you.
Thank you.
Right. Okay. Thank you all so much. This has been lovely. Thanks.